Okay, I'll make a start. Good afternoon and welcome. Thank you for joining us today at SVI's Health Matters webinar. My name's Professor Natalie Sims. I'm the Deputy Director here at St Vincent's Institute. Before we start, I'd like to acknowledge the traditional custodians of the various lands on which we find ourselves today. I'm in my office here at SVI and we're on Wurundjeri land. And I'd like to acknowledge the continuing connection of Wurundjeri people to this land and their continuing roles too as the first scientists and doctors in this country. Today, we're going to hear from two people. We're going to hear first from Anne-Marie Wilton, who's one of many women living with ovarian cancer, our focus for today. And she'll tell us something about her journey. And then we'll hear from SVI's own Associate Professor Elaine Savage, who'll talk about the current state of play in the research of ovarian cancer. After the two presentations, we'll have a short question and answer session where you'll have an opportunity to write your own questions to both Anne-Marie and Elaine. So if you look at your screens, if you're not familiar with it yet, there's a question and answer box, Q&A, at the bar at the bottom of your screen. So, and you can feel free to type your questions at any point during today's meeting, but I'll get to the questions after both of them have had their presentations. So please feel free to put questions in at any point in the Q&A box. We won't be using the chat function or the raise hand. Please use the Q&A because I might miss your question if you raise it any other way. So thank you again for joining us. And for the first part of today's meeting, I'll be interviewing Anne-Marie Wilton. Anne-Marie was first diagnosed with ovarian cancer in January of 2018, and her treatment included a full hysterectomy and chemotherapeutic drugs and immunotherapy, and we'll hear more about her story. In 2010, Anne-Marie had a recurrence and completed another round of chemotherapeutic drugs and immunotherapy. We're delighted to have Anne-Marie here today, and we're actually all in the same building. So I popped down to have a chat with Anne-Marie before she started. And it's really clear that Anne-Marie maintains a very positive attitude and a positive lifestyle by keeping active and social. And this includes walking and hiking most days. She enjoys growing vegetables in her garden. And I was super impressed to learn that she's currently learning to get her recreational flying license. And she showed me a great photo of her next to a yellow plane, which I just think is spectacular. So we're going to start by interviewing Anne-Marie. So I hope you can all see her there. And I'll start, Anne-Marie, with asking you about your journey. And tell us, when were you diagnosed with ovarian cancer and what were the symptoms that you experienced?
Okay, thank you for your invitation today, and also to Ovarian Cancer Australia, and in particular my teal nurse, Catherine. I was first diagnosed in January 2018. The symptoms were pretty vague, actually. Stomach pain, feeling quite bloated, a bit nauseous. I put a significant amount of weight on and kind of lost quite a bit of interest in exercise. They were probably the main symptoms that I had leading up to the cancer. Yeah.
And what were your thoughts when you actually got that diagnosis? Because I understand your journey to get the diagnosis was quite a long one. So how did you feel when you finally knew what was going on?
Yeah, I had been to two previous doctors. It had been missed. I went back to my old surgery. I was then sent off for the appropriate tests and found that it was most likely to be a cancer, an ovarian cancer. So I went to see my GP in the morning, Thursday morning, and I was given the results. I saw the surgeon in the afternoon, and then I saw the surgeon in the afternoon and had surgery the following week. My first thoughts were really, there was no time to process it all. So pretty much I just got on with it. So from day one, I'm like, I just got on with it. And it's almost like I went into autopilot. I quickly developed a very black sense of humor, and that actually helped me, and it continues to help me through the journey. Yeah.
But before you were diagnosed, what did you know about ovarian cancer?
Not a great deal, actually. And there was no history in my family of either breast or ovarian cancer. Like many women, most women, I'm guessing, that it came as a complete shock and surprise that it could be ovarian cancer. So, yeah, I was surprised. I didn't know much about it.
Yeah. And what treatments did you undergo after your diagnosis?
Well, I had a full hysterectomy, debulking. 6 weeks after that, I started chemotherapy. I also did a trial drug, alemtuzumab, and I did Avastin, which I'm now continuing on. I had 5 or 6 months of that, and that was really successful, which was great.
Mm-hmm.
I had the recurrence, as we said, in 2020, and I had more chemotherapy drugs. By this time, I had lost significant amounts of weight. I was also a lot fitter. I had embraced the cancer. I had embraced the journey. And because I was a lot fitter, I didn't need to do the last round of chemotherapy. So instead of having, maybe it was 6, I had 5. So
Mm-hmm.
I think embracing it made a huge difference.
Mm-hmm.
And
Mm-hmm.
I haven't had a recurrence since. Yeah.
And you mentioned that you're currently on a treatment now. What's the treatment that you're on now?
Yeah, I'm having monthly infusions of Avastin. I'm also taking a drug called Zejula. I have 2 of those tablets each night. I've been taking those and haven't missed a day taking them since the end of April last year. And that seems to be working for me, which is great. I'm happy.
That is good. One of the things about you too is that you have a very positive outlook on life. And how is it for you now living with ovarian cancer? How do you maintain that attitude, and what's the impact on you of that?
Okay. I choose a positive attitude. I choose to live with positivity, and I choose a healthy lifestyle. So living with positivity and a positive attitude are quite different. Living with positivity, really, I guess it's a bit of a toolkit for me. So if I open up the toolkit, I've got all my resilience that I've been building up on over the years, reading, I love music, I love hiking, fantastic family and friends. I have a hobby garden, which is also a folly. I love going to the theatre, I love the arts, I love travelling. I really enjoy my life, and most of all, I do what makes me happy.
That's great. I'm going to go a little bit off strict script because we've got time here. Did you always have a life where you did many different things, or have you? It seemed. I'm wondering if you're sort of more energized and doing more because of your new positive attitude towards life.
I think I've always had a fairly positive attitude.
Mm.
Probably now, I had a change in my lifestyle about June last year, and I found since the change in my lifestyle since June last year, I'm now the person I used to be when I was 38.
Mm.
So I've kind of always been a bit adventurous, a risk taker. I've lived in different places, lived in Falls Creek, overseas, Noosa, all that sort of stuff, which was great. And I'm that person again, you know, I can take risks. I'm like, oh, what will I do today, or where will I go? So yeah, I'm more, because I've let go of it, because I have the cancer, I live with the cancer. It's not mine. I'm very happy to give it away if somebody would like it. It is a cancer. You know what? Somebody gets diabetes, somebody else has a stroke. I got cancer. So my attitude is like, so what? I got cancer. You know, it's confronting being given a use by date. But again, I've changed the date on my tombstone, so that's great. And I just keep looking forward. I've inherited my mum's genes. She kept moving forward, and that's what I do.
That's great. What advice or what message would you give to women who are going through a similar journey, who perhaps haven't reached the point that you're at, so they may have just had a diagnosis, or perhaps even for people who know someone who's just had a diagnosis? What advice could you give them?
Sure. I don't know if I'm the best one to give advice. However, I think for me, I can say what works for me. Exercise, a healthy lifestyle, keeping a good weight, minimum amounts of alcohol, if at all. But do what makes you happy. Really, just do what makes you happy.
Mm. And tell us a bit about what motivated you to help us today in talking about your experiences. Why is future research into ovarian cancer important to you?
It is so important to myself and to other women. You know, if I think about some of the young women now who might be in their 20s or 30s, and they have young girls of 8 and 10 years old, well, those girls may not have their mums sitting beside them when they have their first period. So, I mean, that's pretty tragic, isn't it? And then they won't grow to be mothers or grandmothers. I mean, what a world it would be if we had no ovarian cancer. If I can use a quote from Mr. Albanese just before the election, and he said something like, if we lift up the economic status of women, we lift up the whole nation. So if I could reword that and say, if we lift up the significant amount of funding and the awareness of ovarian cancer, then we lift up the lives of women living with ovarian cancer so that they can have healthy lives, so that they can get to see their grandchildren and live a life that we all expect to live when we're young women. Yeah.
That's a really great message, Anne-Marie.
Thank you.
Yeah. I can see we've already got questions starting to appear in the Q&A, and we will get to those questions. But first, we're going to have Elaine's talk about treatment and research into ovarian cancer. Some of what she's saying might answer some of your questions, and it might raise new questions for you. So please continue to put your questions into the Q&A box, whether they're for Anne-Marie or for Elaine. And if you can write who the question's for, that will help, but you don't need to. We might ask it of both of them, and we'll get back to your questions after Elaine speaks. Anne-Marie, thank you so much for joining us today, and thanks for sharing your story and for staying on to tell us more about your experiences and answering the questions.
Pleasure. Thank you.
I'm now going to introduce Elaine Saanich, Associate Professor Elaine Saanich, who's a cancer biologist. She's a lab head here at St Vincent's Institute of Medical Research, and she's supported by a Victorian Cancer Agency Mid-Career Research Fellowship. Elaine received her PhD from Monash University in 2003, and she was awarded at the time a Cancer Research UK Fellowship. And she used this to undertake postdoctoral studies at the London Research Institute. Elaine then worked at the Peter MacCallum Cancer Centre, starting in 2006 as a Senior Research Fellow, and she joined SVI just last year in 2021, and we're so glad that she's here with us. Elaine is internationally recognised in the field of targeting RNA polymerase 1 transcription and in the DNA damage response and how that's used in cancer therapy. Elaine's research is focused on developing new cancer therapeutics and new combination therapies to address what is a significant challenge of refractory ovarian cancer, and she also works on multiple myeloma. So Elaine, I'll hand over to you for your presentation now. Thanks, Elaine.
Thank you so much, Natalie, for the introduction, and it's so wonderful to have this webinar to raise awareness for ovarian cancer and to hear from Anne-Marie. And I love your positivity, Anne-Marie. And you know, my research is focused on developing effective treatments for ovarian cancer, because like you, I want women with ovarian cancer to live a long and healthy life and to grow old with the people they love. So today, as I said, we're focusing on ovarian cancer, but if there are any issues that stand out to the people listening today, they should discuss any issues with their GP. So as Natalie mentioned, I thought I'll give a bit of introduction about myself. So I moved to Australia with my family when I was 17. We immigrated here, and I always loved science and loved study. I was good at school. So soon after we arrived in Australia, I enrolled in a science course at Monash University, and that's where I did my PhD studies, and I loved academic research. After my PhD studies, I was awarded the Cancer Research UK Fellowship, went to London, and that's when I started working on cancer to understand how cancer cells grow and divide uncontrollably. Came back to Peter Mac, and as Natalie mentioned, I established my lab at SVI last year with support from SVI Discovery Fund. I'm also a mother of two beautiful kids, and this is an old picture. My daughter now is in high school and my son is in grade 4. They love science, and so far they're active listeners when I talk about my research, and they ask me questions, so it's a good sign. And as I said, I in the last 5 years, my research has focused on ovarian cancer research, and there's a lot that we don't know about the biology of ovarian cancer. And ovarian cancer is actually describes few different subtypes of cancer, they all share they all share the location within the body. So there are three main types of ovarian cancer that can be defined based on the origin of cancer cells. So within the ovary, there are stromal cell, epithelial cell, and germ cells. And epithelial ovarian cancer is the most common subtype of ovarian cancer. And there's also the cancers of the peritoneum, which originate from the lining of the abdomen. So all these cancers are defined under ovarian cancer, but epithelial ovarian cancer is the most common, and it's thought to arise from the lining of the fallopian tube. So this is the tube that connects the ovary to the uterus, and this epithelial cells that line here, this distal part of the fallopian tube, is thought to be the origin of epithelial ovarian cancer. And all these cancers have similar symptoms and similar treatment plan. So how common is ovarian cancer? Sadly, in Australia, 1,700 women are diagnosed with ovarian cancer every year. And risk of developing ovarian cancer increases with age. So it's about 1.2% of women that develop ovarian cancer by the age of 85. About half of women that are diagnosed with ovarian cancer are around the age of 63 or older. And unfortunately, they are mostly diagnosed at an advanced stage. And this is because the symptoms, as Anne-Marie said, the symptoms are vague. They can be similar with other conditions or misdiagnosed. So the common signs are abdominal bloating, abdominal pain, appetite loss, changes in bowel habits, frequent urination, unexplained weight loss or gain, fatigue, and also pain during sex. Unfortunately, there is no early detection test for ovarian cancer. So there were studies from the UK and the US that examined the benefit of screening using ultrasound, pelvic exam, and also a marker in the blood, CA125. And they found that with that screening, they were able to detect stage 2, early stages of ovarian cancer, but that did not lead to a reduction in mortality rates. So there was no benefit from the screening in those studies. And that highlights the need for better screening tests, but also for better effective treatments. And as similar to all cancers, ovarian cancer is linked to genetic mutations. So 1 in 4 ovarian cancers is linked to inherited gene mutation. So all women with ovarian cancer are referred to genetic assessment to identify genetic risk. And if they fit a certain criteria, they are offered genetic testing. And if a faulty gene is found, this can change the treatment plan and the follow-up care, and also access to clinical trials. But also it can inform family members about the possibility of this gene being inherited and passed on through the family. So then other family members can be offered genetic testing. And if a faulty gene if a woman is found with a faulty gene, she may want to consider risk-reducing surgery, and that's involved removing the ovaries and the fallopian tube. And this is not an easy decision to make. So what causes ovarian cancer? As I said, cancer cells start to grow uncontrollably, and this is linked to genetic mutations. And there are 2 kinds of genetic mutations. One that is inherited through the family, and this is called germline mutation. But there are also mutations that arise later in life, and these are called somatic mutations. And this is why the increase in age is linked to higher risk of ovarian cancer. There are also other health conditions, medical conditions that are linked to ovarian cancer, including endometriosis, hormone replacement therapy, tobacco smoking, and obesity are linked to a high risk of ovarian cancer. But there are also factors that reduce the risk of ovarian cancer, and they include having children and also the oral contraceptive pill. So the most common tests to investigate symptoms of ovarian cancer include imaging using ultrasound and CT scan and MRI scans. The blood test that look for cancer marker, CA125, but this marker is not specific to ovarian cancer. And also biopsy. And really the biopsy is the real test that can determine ovarian cancer. And this is usually done as part of the initial surgery. And usually, you know, the pathologist looking under the microscope can identify changes in the section of the biopsy, and also the genetic makeup of the cells can also define the type of the ovarian cancer. Ovarian cancer can also be classified into stages, and that's determined during surgery, defined by the size of the tumor and how far it has spread within the abdomen. So stage 1 is when the tumor is localized to the ovaries, to 1 or 2 ovaries. Stage 2 is when the tumor is localized to the 1 or 2 ovaries and also within the pelvis, organs within the pelvis like the uterus and the bladder. In stage 3, the tumor has spread outside of the pelvis into the abdomen. And in stage 4, it has spread beyond the abdomen to other organs like the lung and the liver. And unfortunately, 70% of all ovarian cancer cases in Australia are diagnosed in stage 3 and stage 4. And that's, like we said, is due to the vague symptoms and misdiagnosis of the symptoms. But also the biopsies and looking under the microscope can enable another level of classification of ovarian cancer, and also the genetic alterations in the cancer cells can define those types. So there are type 1 and type 2. So type 1 can include low-grade serous ovarian cancer, clear cell, endometrial, and sorry, I can't see the last one here. And they defined as type 1 because the tumor is localized to the ovary, and also they're non-invasive. And that can be determined in the histology section. However, the most common type of epithelial ovarian cancer is high-grade serous, and it's a type 2, and it's an invasive cancer, and it's defined by genomic instability. And this is because half of the cases of high-grade serous ovarian cancer are associated with either inherited or somatic mutations in DNA repair genes. So the BRCA1 and the BRCA2 genes are known as breast cancer susceptibility genes. They function in the normal cells to repair DNA damage that naturally occurs. So in the absence of these genes, the cells can't repair the DNA, and that leads to accumulation of DNA damage within the cells, and that leads to amplification of other genes around the genome and eventually leads to cancer. So BRCA1 and BRCA2 are two components of a DNA repair machinery, and other factors within this machinery can also be mutated. So there are many genes are involved in this machinery, and mutations in other factors have also been linked to ovarian cancer. And like I said, 50% of cases of high-grade serous ovarian cancer have defects in DNA repair. There are other alterations, and my studies have focused on two main pathways, the PI3 kinase pathway and the RAS-MAP kinase pathways. And these are growth signaling pathways that promote cell growth and proliferation. And type 2 cancers have poorer outcome compared to type 1. And the recurrence is a really significant challenge in the clinic. So as I mentioned, most women with ovarian cancer are offered genetic assessment, and if they meet certain criteria like clinical, personal, and or family history, then they can be offered genetic testing, and that will determine the treatment plan and also the follow-up care. So treatments can vary depending on the cancer stage, the patient age, other medical conditions, and plans to have children or personal preferences. But surgery is commonly the first initial step in the treatment and debulking surgery. Therapies, mainly chemotherapy is the standard of care. So chemotherapy is a combination of two classes of drugs. One is the platinum compounds and the other is taxanes. So the platinum compounds such as cisplatin and carboplatin work by damaging the DNA. And taxanes work by stopping the cells from dividing and reproducing. Chemotherapy damage the cancer cells, but they can also damage normal cells, and that's why chemotherapy have bad side effects. Another class of therapy is targeted therapy, and this is more specific to the cancer cell. So it targets the cancer cells and it causes little damage to normal cells. And there are two classes approved for ovarian cancer, and these include the angiogenesis inhibitors, Avastin, which Anne-Marie talked about, and also PARP inhibitors, and Anne-Marie also referred to Zejula. So Avastin works by blocking a specific molecule, VEGF, and the cancer cells produce VEGF to create new blood vessels that feed the tumor. So by blocking this molecule, the tumor starves and shrinks. On the other hand, PARP inhibitors work in a different way. So PARP inhibitors inhibit a protein called PARP, which is important for DNA repair. And it works in a different pathway to the other DNA repair machinery that is normally mutated on ovarian cancer. So when BRCA, for example, BRCA1 and BRCA2 are mutated, and then the cells are treated with a PARP inhibitor, they can't repair their DNA, and DNA damage accumulates, and that specifically kills the cancer cells. While PARP inhibitor does not affect normal cells because they have other pathways to use to repair their DNA. And another way to enhance the therapy is exercise and healthy diet. So the research have shown that women who have a healthy lifestyle do better on treatment, and they experience less anxiety and depression. And that nutrition is also part of a healthy treatment plan when having ovarian cancer and ovarian cancer treatment. In this slide, I wanted to summarize the challenges of the recurrence in ovarian cancer, and also summarize the timeline of introducing treatment in ovarian cancer. So chemotherapy was approved in the late 80s, and we're now almost 40 years later, still the standard of care for ovarian cancer. Paclitaxel, the taxanes compounds, were added in the late 90s. And PARP inhibitors have been remarkable. So PARP inhibitors were approved just 6 years ago, but have shown dramatic and durable benefit in a subset of patients with BRCA mutations. And Avastin was only approved recently in 2018. So the challenge in the clinic is reoccurrence, particularly high-grade serous ovarian cancer. And we know now that a subset of patients, especially BRCA mutated ovarian cancer, they respond very well to PARP inhibitors, and we have seen durable benefits beyond 6 years. But there are a subset of ovarian cancer that relapse and does not respond to PARP inhibitors. And the research is now focused on understanding the biology of resistant disease. So can ovarian cancer be cured? It is possible to live a long and healthy life after ovarian cancer diagnosis. And the current research is focused on developing and testing more effective treatment. And there are many clinical trials that target resistant disease. And research is focused on understanding why, in some cases, ovarian cancer respond well to treatment, and what are the factors that define and influence response to treatment. And we want to understand how cancer cells develop resistance to treatment. So specifically, our research at St. Vincent's Institute aims to understand how ovarian cancer can develop resistance to PARP inhibitors and chemotherapy. Because if we understand the biology, we can then identify weaknesses in the resistant ovarian cancer that we can target with new therapy. And we're currently testing so we can optimize the efficacy of a new therapy that is showing promising results in early phase clinical trials. So I've been working on a new drug called CX-5461 for the last 10 years now. And we have shown that it works in a unique way. It induces stress specifically in a in a specific location within the cancer cell. So it doesn't induce collateral DNA damage like chemotherapy. So we think it'll be better tolerated in the cell and will have lower side effects than chemotherapy. So it induces a low level of damage, but that is enough to inhibit the growth of cancer cells. And we have shown in a lot of, in preclinical models of ovarian cancer that it's effective in inhibiting growth of tumors grown in our in vivo models. They are preclinical mouse models of ovarian cancer. So we've been working on this drug, as I said, for a long time, and we showed that it was also effective in blood cancer models. And that led to a first-in-human trial of this drug in patients with advanced and very challenging blood cancers. And it showed promising results in about a third of the patients enrolled in the trial. And a more recent trial of this drug in solid tumors showed that it had durable benefits, particularly in breast and ovarian cancer patients with BRCA mutated cancers. So, and based on these results, the FDA has recently fast-tracked a designation for CX-5461 as a promising therapy for BRCA mutated ovarian and breast cancer. And we currently at the PIRAMAC, we have a new trial testing this drug in combination with a PARP inhibitor in patients with metastatic prostate cancer. And we're actively seeking funding for a new phase 1 trial of CX-5461 in patients with ovarian cancer. Finally, I just want to introduce my lab. We are a collaborative team of 5. We have 5 PhD students, research assistants, and postdoctoral scientists. But we are part of a bigger network of clinical and research collaborators and consumer partners. So I worked with Judy and Leslie for over 5 years now. So they contribute as patient advocates to our research. And I also want to acknowledge our funding support, particularly SVI Discovery Fund, who helped me establish my lab at SVI. Thank you so much for listening, and I'm happy to answer questions.
Thanks so much, Elaine, for your talk. Now it's over to you. Time for your questions. If you've got a question for either Anne-Marie or for Elaine, or for both of them, please use the Q&A box at the bottom of your screen. Just click on it and put your question in there. If we don't get to your question today, don't worry, we'll still get it answered. We'll respond during the week with an email. But please pop your questions in. We've already got some there. So I will get started in asking Anne-Marie and Elaine some of your questions. Anne-Marie, the first question is for you. Can you tell us about the side effects that you experienced on chemotherapy? And actually, there's 2 questions for you. So we might just start with that one. So what are some of the side effects that you experienced on chemotherapy, or perhaps what you've heard from other people as well? Oh, you're still muted, Anne-Marie. No, you're still on mute.
There we go.
There we go. Gotcha.
Okay. All right. So side effects of chemotherapy were severe nausea, fairly significant bone pain, headaches, like migraine sort of headaches. Because I was on the trial drug, I think also a side effect of that was it affected my eyesight. I developed a peripheral neuropathy. There were days when, a couple of days when I actually couldn't walk. My feet did not work. And I remember one day I had to crawl up the stairs to get upstairs. It also affects your personality. It's like a whole personality goes flat. And some days I'd think, oh, you know, I'll get out of bed in 5 minutes, or 8 hours would go by and I'd be sort of still in bed. However, what I did do is that I started changing the way I thought about it, and I started thinking about the chemotherapy as an adventure. So when I went to have chemotherapy, I would play over and over and over again songs by Coldplay, A Sky Full of Dreams. So I would listen to that over and over and over, and I'd be like sitting there really happy with my headphones on, and I would imagine myself walking down that street in Sydney with the band. That was really helpful because it got me into another headspace. And also to, you know, then I started getting some better medications, you know, anti-nausea medications, some pain relief. The other way I did pain relief, I did a little bit of exercise, and I used to have a lot of baths. That was also part of my pain relief. When I came to the second chemotherapy, I had gemcitabine and carboplatin and Avastin. Because I had embraced the cancer and I embraced the treatment, I did 100% better. Two things: because I'd lost weight and because I was a whole lot fitter. And I'm like, yes, here's a new adventure. Everyone is different. Everyone has a different experience of this. You know, every experience is quite unique. But I sort of went along with a different attitude about it, because I thought, you know what, this is great. You know, this is getting rid of the cancer. So that's kind of how I managed it, really.
Thanks. That's really helpful. Thank you. Elaine, a question for you. Is it known why there's different outcomes for the different types of cancer? So you talked about it being in the different cell types in the ovary. So are there different outcomes, and are there different times when they're diagnosed? So are some of them more easily detectable than others? So tell us about those 3 different cell types.
Yeah, so the type 1, which are the rarer types, they actually, because they are non-invasive, surgery is usually effective. So the tumor is removed and it responds to treatment, chemotherapy. And we actually don't understand a lot about the biology because they are rarer cancers than the epithelial ovarian cancer. We don't know much about it. It really requires an international effort to collect enough samples to understand the biology of the disease. We do think that the genetic makeup and also the molecular, like we know that gene expression, not just the gene, it's the, you know, the expression, different pathways of expression of the genes that can affect the type of the tumor. So more work is required internationally to understand the biology of the rarer subtypes of ovarian cancer. Within high-grade serous, which is the most commonly studied ovarian cancer, we know there are 5 different subtypes, molecular subtypes. So that's not defined by the genetics. It's actually defined at the level of RNA gene expression. And we know within those, some are more aggressive than others. For example, some with a cyclin E amplification or MYC amplification have poorer outcomes. So yes, the genetics makeup can determine the response to treatment.
And just a follow-up question to that, you mentioned that one of the things that's really needed is these international networks so that these more rare forms of cancer can be analysed. So do these networks already exist, and
Yes.
are you involved in some of them?
Yeah, my collaborators are, so my collaborators at the Peter Mac are involved in the ICGC study. So there's actually the Australian ovarian cancer study, so led by David Botel, Professor David Botel at the Peter Mac. It's actually one of the largest and well annotated biobanks in the world. And it's an open resource to scientists, so we can access samples to grow preclinical models and do more research. So yes, and it's part of a bigger international cohort. Yeah.
Great, that's really good to hear.
Yeah.
Anne-Marie, I've got another question for you. In your mind, what should the priorities be in terms of developing new treatments for ovarian cancer from your perspective?
Well, I guess if I can wind back a little bit, I do have high-grade serous ovarian cancer, grade 3C, which is a popular one. So I think, no, sorry, if you can just ask that question again.
The priorities for new treatments.
Gosh. Wow. So women can live longer lives and healthy lives. And, you know, if there's no test available, if there can be very early diagnosis, different treatments that may be available to, like the Zejula. I am not BRCA positive and I don't have the HRD. I'm just extremely lucky that I'm doing really well on that. So, you know, are there other drugs out there? And what else is going on the genogram that actually I'm doing so well on this particular drug? Yeah. More research to find out, you know, what are the other links?
Yeah.
So if I could add on this, Natalie,
Please.
The immunotherapy has worked really well for blood cancers and also small lung carcinoma, and it's not effective as a single agent in ovarian cancer. If we can find ways to make immunotherapy effective for ovarian cancer, that would be a game changer, because we think immunotherapy is the only way to have durable responses against the disease. So this is a big area of research at the moment as well.
Elaine, I'll follow up with another question for you. This is from Shelley. Are there any current trials for HGSC peritoneal cancer?
Yes, I think so. So there is an Australian clinical trial registry that people can browse and see what's available, because there'll be clinical trials that are across multi-sites. You know, if it's not happening in Victoria, it can happen in New South Wales. A lot of the clinical trials that I'm aware of are happening at Peter Mac. So, you know, a referral to a medical oncologist at Peter Mac can also inform about what trials are available.
And I think that there was a question from Rhonda, which was similarly asking about how she can check for eligibility for your trial in particular. Is that something that she can check through ANZ GOG?
Yeah, so our trial is not open yet because we don't have funding to run the trial. So yeah, unfortunately, we can't do it yet. But we hope we can have this drug available for Australian women, but funding is shocking.
Yeah. When it does come up, when it gets funded, rather than
it will be listed on the registry, on the Australian Clinical Trial Registry. Yeah.
Great, thanks, Elaine. Back to you, Anne-Marie. Shelley has been very struck and she's loving your positive attitude, and she wants to know whether you have any down days at any time.
No, I don't. I don't do blue.
Excellent.
I'm wearing blue, but I don't do blue.
I love that. We're going to leave that at that. That's so good. Elaine, back to you. One of our attendees has asked what you see as being the most exciting developments in ovarian cancer in the next 5 years. What's on the horizon?
In the next 5 years, particularly targeting, so two things, the immunotherapy, I think, but it's going to take time. The other thing is, and we know now how the cells can rescue the DNA damage induced by chemotherapy. And there are two potential drugs. One is the ATR inhibitor, one is the POLQ inhibitor that are in clinical trials targeting chemo-resistant ovarian cancer. So there are a couple of agents in the pipeline.
Great. And we just had a response from Shelley, who said, Anne-Marie, she's really glad to have heard that you don't do blue and she's working on it. So some positive feedback for you there.
Thank you.
Anne-Marie, I've got the question for you from Shalini, who firstly says she's very proud of how you've kept fighting through the journey, and she says it's truly amazing. Her question is whether you had any signs during your younger years, perhaps when you're a teenager or your early 20s, irregular menstruation or bloating or PCOS, or any symptoms that you had to start off with.
Just the usual hormone stuff at 15 and 16, nothing unusual.
Yeah. And this is a double-barrel question because Shalini's also asked Elaine whether PCOS or earlier symptoms have been linked to ovarian cancer.
Okay.
No, I'm not aware of that. I'm sorry, I'm not aware of that.
Yeah. All right. Sounds like that's a question still to be answered.
Yeah.
All right. We have a lot of questions, which is fantastic. Yeah. I'm really glad that people are engaging so much. Someone else has asked, maybe Elaine, I'll send this one to you. So when fluid builds up in your body and it contains cancer cells, does chemo or the targeted therapies do anything to those cells? So this is, I guess, about cancer cells within the circulation or within fluid in the body.
Yeah. Yeah, I believe it can, but I'm not sure of the answer actually. Yeah, but I believe it can, especially because chemo is given IV.
Yeah, so probably the chemo might be effective, the targeted therapies, maybe that's an open question at this point. Great. There's so many things for me to get to here. Yeah, but this is great. I'm really excited. And don't forget, I did say that if we run out of time, we will still answer the questions by email, but we've got plenty of time, which is great. Rhonda Chapman has asked, what's HRD?
HRD, so that stands for homologous recombination deficient tumor. So homologous recombination refers to the DNA repair pathway. So that means the tumor is deficient in its ability to repair the DNA. So that's usually like whether it's a BRCA mutation or other mutations that make the DNA repair defective, which is the initial aspect of the normal cell becoming a cancer cell. Hope I explained that properly.
Can I add something in there?
Please.
I know that I don't have the HRD and I'm not BRCA positive because I did a genomic test at Peter Mac when I had the reoccurrence. So that tested all my genes. And the advantage of that, which would be fantastic if that was available to all women, is that I now have a possibility of a drug down the track. So that wouldn't have come through, I understand, from genetic testing, I don't think, but from all your genes. Yeah.
Yes.
I did that test. And that was something that I paid for. That was an out-of-pocket expense.
We've got a question from Carolyn who has high-grade serous stage 3 non-BRCA. She's in her first 6 months since diagnosis, and she's had chemo and surgery and now chemo. She's asking what research, maybe this is a question for Elaine, which research is most promising at this stage for those like her who are in the largest and most lethal group? What do you see as the most promising thing?
My understanding for non-BRCA, it's still chemotherapy.
Yeah. And then Yanka has asked whether somatic mutations later in life of ovarian cancer, whether there's evidence that they're caused by environmental causes or age-related DNA breakdown leading to cancer cell proliferation.
It's normally related to age. Yeah, we don't really understand yet the impact of the environmental, but for example, tobacco smoking is linked to cancer. Unhealthy lifestyle and healthy diet is linked to cancer, but normally the accumulation of mutations with age is the link to cancer as well.
Yeah. Okay. Josie has asked what's an average time for treatment that a patient would go through? And so maybe perhaps we'll get Anne-Marie to answer first about how long her treatment has gone on for, and then maybe Elaine, you can give us more context of what the general answer would be.
Sure. My chemotherapy treatment started in February and I think it finished in the May, so 5 or 6 rounds. And I had Avastin to start with in the February, and that went through to the following year till May. When I had the reoccurrence, I started on Avastin again, and I continue now on monthly infusions of Avastin, which works well sitting alongside the Zejula.
So basically, once you started, you've continued on the whole time with therapy, and it's just different phases of therapy at different times, essentially.
Yeah. Well, I had the time when I didn't have any treatment, and that was, as it was, but then I had the recurrence.
Yeah. Elaine, can you offer a perspective on it?
Like I said, I'm not a medical oncologist. So as Anne-Marie said, chemotherapy is given in cycles, and then the treatment stops. However, PARP inhibitors are given as maintenance therapy. So after the chemotherapy, they're given as maintenance therapy. So they taken daily. Yes.
Yeah. We've got some lovely positive feedback, which I'll share with you later so that we've got time for more questions. One of the questions is whether there's any evidence that having children later in life increases the risk of ovarian cancer. Is there anything known about that? Elaine, maybe that's a question for you.
I'm not aware of that, no.
Okay. And a practical question about whether patients who want to arrange genomic testing, whether they would do that through their oncologist or their GP, or do they go directly to Peter Mac? How does that work?
My understanding is the GP sends a referral to a medical oncologist.
Yeah. Was that your experience, Anne-Marie, that it went?
No, mine was through my oncologist.
Okay.
When I had the reoccurrence, he suggested it and I thought it was a good idea.
Mm-hmm.
Yeah.
Sounds like a patient could speak to either and find out.
I think the referral goes to the referral from the GP goes to the medical oncologist, and then the medical oncologist, can recommend the genetic testing. Yeah.
That makes sense. Thank you. Have there been any advances in risk reduction medications or treatments for those with BRCA mutations?
So the risk reduction is usually the surgery, and I believe that has shown to be effective, but it's a dramatic option, removing the ovaries, removing the fallopian tube, removing the breasts as well. So it's really a dramatic decision, but I believe the data showed that it showed efficacy in reducing risk.
Great. And then I think the final question before we wrap up is really about trials and advances in screening methods. So one of your key points, Elaine, was that really people aren't diagnosed until quite late, until they're at stage 3 or stage 4. What's out there for new screening methods? We don't know a lot because we still need to learn more about the biology of the disease in order to define markers to measure in the blood. There was a heartbreaking study that came out from the UK last year that measured the CA125 marker in the blood for over the 30-year period. And although they detected, through the study, they were able to detect early stages of ovarian cancer, that did not lead to reduced mortality. So although these women were diagnosed earlier and they started the treatment earlier, they had the similar outcome to what you would normally expect for later diagnosis. So in that study, early detection did not have benefit. And it was really a heartbreaking study for researchers that were working on it for over 30 years. Yeah, because we sort of see what happens in the breast cancer field, and now screening for breast cancer is so well advanced. And Mandy, who's listening, made a good point about that.
There is more research going into breast cancer. There are more options for treatment in breast cancer. Ovarian cancer has been neglected for a long time.
Yeah, that is true. That is true. And we're hoping that by today's session, it will help to raise some awareness about ovarian cancer and the need for more research into ovarian cancer. That's all we have time for today. We've got some lovely positive questions from Marianne and Rhonda, which I'll pass on to Elaine and Anne-Marie. I want to finish up by saying thank you to Associate Professor Sanej and to Anne-Marie Wilton for joining us today. But also thank you to all of you who've come along for attending. If you do want to watch the webinar again and perhaps catch something that you missed, or you have friends or family that might be interested in watching it, we're going to send around a recording in the coming days that you can access. We'll also send out a survey so we can get your feedback and you can tell us what other topics you would like to hear about, and so we can improve our delivery of virtual events as well. And so please, when you see that come through in your email, please take the time to complete it. We'd love to hear what you have to think. If you want to make a donation to support our research into ovarian cancer or to any of the other conditions that we work on here at SVI, please go to our website. It's svi.edu.au, and I'm going to put that link in the chat so that you can copy and paste that into your web browser now or later. That's our website, or you can get in touch with some of our team at the foundation. And I will also put the email address for our foundation into the chat so that you can see that. Looks like I can only post to the panelists. All right, I will have to tell you what the email address is. Oh, there it is. It's now on the slide. Fantastic. Good. So you can get the recording as soon as it's up from our website, from our YouTube page, which is there. Our website address is there, svi.edu.au. There's a donation button on our website. Or if you want to get put on our mailing list, if you're not there yet and you want to receive event news or research news from SVI, or you want to hear more about our work, please get in contact through our website, or you can email. There we go. A message has just gone through to everybody of our foundation, which does all of our fundraising for our work here. So that's foundation@svi.edu.au. I really hope you've enjoyed our session today. I've learned a lot. And thanks again to Anne-Marie. We are all inspired with the motto of "I don't do blue," which thank you for wearing your blue dress to remind us of that, and we'll keep that in mind. I think it's provided a lot of encouragement to some of our listeners today, very much so.
Yeah, thank you.
So thank you for joining us, everybody, and enjoy the rest of your day. Thanks a lot. Bye-bye.
Thank you. Bye.